The following is a video presentation on bicortical proximal subpectoral biceps tenodesis. The patient is positioned with the right arm in the 90-90 position held by the tremano. An incision is made along the inferior aspect of the pectoralis tendon. Soft tissue and blunt dissection is carried out to carefully identify the pectoralis and the short head biceps. Dissection is carried underneath the pectoralis. A band of fascia may be broken up. Using blunt or finger dissection, can reach up, feel the humeral shaft, and often feel the biceps tendon rolling underneath your finger. An Army, Navy, or often a Homan retractor is then placed to move the pectoralis out of the way. Importantly, to dissect or retract the medial head out of the way, because this is where all the neurovascular structures lie. Then the long head is identified, pulled out through the wound. A whip suture or FiberLoop is placed into the biceps tendon, starting at the musculotendinous junction, traveling approximately 4 throws or 2 centimeters along. The final throw of the whipstitch is placed in back of the last throw, locking it into place. The biceps is then cut, residual aspect discarded. The 2 suture limbs are then passed through the biceps button, one limb coming through laterally, traversing the button and exiting medially. In a reciprocal fashion, the other limb starts on the medial side, traverses the button, and exits laterally. This is done with the same Keith needle applied to the FiberLoop. This has now affected the tension slide or zip line of the biceps. This is folded over and held with a mosquito so that it does not unravel. A vicryl is passed through the biceps to later shuttle at the end of the case and lock the biceps into place. The biceps is sized. This is typically a 5.5 to a 6.5, and the drill that will be used is line to line. The pectoralis is pulled out of the way, again with the Army, Navy, or a Homan retractor. Important retraction of the medial head. The 3.2 guide wire is placed through in a bicortical fashion. Surgeons are often curious about the safety of this. In a study looking at the proximity of axillary nerve to button in a subpectoral fashion, the average is approximately 4 centimeters away from the axillary nerve. So this is indeed very safe, quite far from both median and radial nerves as well. A unicortical drill hole is made in the humerus. This is again line to line with the biceps, 6 millimeters in this case. The drill and the pin are removed. The wound irrigated, suctioned out. The button passer is loaded onto the button. All 4 limbs of the FiberLoop are grasped. With tactile, you can feel the button pass through. Surgeon ensures the button is flipped, and then takes the 2 limbs and toggles them to allow docking of the biceps into the humeral hole, as you can see. The FiberLoop is then passed through, or this is passed through with a free needle to lock this into place. This is an important step. The limbs are then cut. Surgeon can evaluate the tenodesis. The musculotendinous junction is entering into the tenodesis hole, and strong pull on this shows that it's quite a secure repair. Subcuticular closure is carried out. Local anesthesia is applied into this wound, as nerve blocks typically don't cover the axilla as well. Post-operatively, we'll follow a rotator cuff repair. Otherwise, absent that, sling for 72 hours, move as pain allows, and no more than 5 pounds lifting for the first 4 weeks.